On to Unit 2 Blood Collection, Part 1, and this correlates with your textbook, Chapter 13. In the first part of Unit 2, we will talk about all things surrounding blood collection from the donor. In Part 1, we're going to talk all about the actual collection of donor blood. The collection must be performed by well-trained personnel. You can't take a phlebotomist and put them in a donor center and expect them to know how to do it. It's a totally different animal. Materials that are used for blood collection are FDA approved and sterile and single use. I don't know how these rumors get out, but every now and then you get these things that, oh my gosh, they're reusing the materials, they're reusing the needles. Don't go donate blood. And of course, that's not good for us because donor blood is a very finite resource. During the process of blood collection, just like with any venipuncture, the identification of the donor is critical. You will have paperwork that the donor brings with them, and so you will identify the donor record with the donor, just like you would a blood requisition with a patient to collect tubes of blood. You will attach numbered labels that are provided to all of the processing tubes and to the blood bag, to where we now have created the trail of identification between the donor and this unit of blood. And then before the donor leaves, you do a final recheck, because again, this is just like in a regular venipuncture. Once you leave the patient, you've broken the chain of custody or identity between the blood bag and the donor. So the final check is done at the side of the donor, and just recheck. After verifying the identification of your donor, you will prepare the site. You want to inspect both arms for signs of IV drug abuse. When I first started donating blood, before I started teaching, they would always ask me, to look at both my arms. I said, well, I want this one. This is my best arm. They said, oh, I know. And then I discovered later on that they were looking for track marks, which didn't make me feel too good, but oh well. You want to select a large, firm vein in an area that's free of scarring, which would really hurt, or skin lesions, which, why would you go through a skin lesion? Absolutely not. The vein selection priority is the same as the routine phlebotomy, that you want the median cubital vein is the best site for blood collection, because it's well anchored in tissue and they're usually pretty large. Bacteria on the skin, if present, may grow very well in stored donor blood and can cause a fatal sepsis in the recipient. When performing blood collection on a donor, gloves are optional. I still find this hard to believe, but OSHA has provided specific exemptions for drawing volunteer donors. And I guess that's the main point here, is these are volunteer donors. They've come out of the goodness of their heart to donate blood. Their blood will be tested for all the disease markers that we have available. Gloves should be worn by personnel in training because they're just learning to work with all this different equipment, and that's when mistakes can happen and potential skin puncture can occur. When collecting autologous units, because these are not volunteer donors. These folks have come to donate blood to be used only for them. If an employee has cuts, scratches, or breaks in the skin, you want to not only wear gloves, but put a Band-Aid over the site and then put on your gloves. You will use a 16 to 17 gauge needle to collect blood from a single venipuncture within 10 minutes. I always told my students that we use 18 gauge needles. Well, no, it's 16 to 17, with 16 being the most popular. That is a huge hole. And you can only use the equipment once. So if you miss the donor on the first attempt, you have to throw that equipment away and get all fresh. And the blood must be collected within 10 minutes. The first 30 to 45 mLs of blood is diverted to a pouch to collect the skin plug and also provide blood samples for testing. You want to mix the blood bag frequently or use the shaker, and most places use the shaker. If not, you come by periodically and jiggle the bag very fast. There's a lot of additive in there that needs to be mixed with the blood because inadequate mixing can result in clots and the donor unit cannot be used. You would collect 450 to 500 mLs plus or minus 10% of blood. They talk about a pint of blood, but in actuality it's 450 to 500 mLs. So the picture below illustrates a blood collection system. There's an anti-needle stick protector, covers the donor needle upon removal from the vein to prevent accidental needle stick injuries. So what applies to routine venipuncture also applies to donors. There's a pre-attached vacuum tube holder that facilitates securing blood samples for testing for all the various infectious diseases. Then there's the sample pouch, which is used to collect the first portion of blood from the donor and prevents contamination from indigenous bacterial flora on the skin. And this was a game changer. Since the implementation of having this sampling pouch, the number of units contaminated with bacteria have dropped dramatically. Donor reactions are not uncommon, and that's why you need to be aware of your donor and check on them frequently. One of the most common is syncope, which is fainting. When that occurs, you want to remove the needle immediately. Hyperventilation, when patients start breathing in and out too quickly, which can lead to fainting. If you notice the donor doing that, go ahead and have them rebreathe into a paper bag. Some of the less common reactions are nausea and vomiting, twitching and muscle spasms, hematoma, and keep in mind with a 16 gauge needle, if the donor has not stopped bleeding, this can result in a large amount of blood leaking into the tissues, causing a huge hematoma. Upper extremity deep vein thrombosis, convulsions, these are very rare, get immediate assistance. Any cardiac difficulties, get emergency care, follow the protocol of your institution, and record any donor reactions. So I had a graduate of my program that said, Terry, they finally told me not to come donate blood anymore. I said, why? She said, every time I donate, right at the end, I faint. And I said, well, sorry about that, but it's probably a good thing. So the donation is complete and the needle's been removed. So for post-phlebotomy care, you want to have the donor apply pressure for 5 minutes with their arm elevated. That's a big hole, and by reducing the blood flow to the area will enhance clot formation so that they will stop bleeding. And I always tell them, and I may even demonstrate on their own arm, be sure and apply firm pressure. After 5 minutes, check the wound for bleeding and bandage the site if the bleeding has stopped. If the bleeding has not stopped, have them continue to raise their arm and apply pressure. Once the bleeding is stopped and the site is bandaged, have the donor sit up for a few minutes. This is so that they can acclimate for the reduced blood volume. It's not a lot. 450, 500 cc's in the big picture is not a lot of blood, but it's enough that when you rapidly sit up, you can become dizzy. After they've sat up for a few minutes and they stated that they're not dizzy, go have them go to the refreshment area for an additional 15 minutes of monitoring. So there will be a qualified staff member who will continually look at people to make sure that they're doing okay. And she may even, or he may even, go around and ask, hey, how are you doing? So they should have a list of instructions for post-phlebotomy care. Number 1, eat and drink before leaving. They always have cookies or juice or sodas, and so grab some snacky stuff and grab something to drink. And in my donor center, they used to have little baskets of cookies and baskets of snacks not wrapped up. And that stopped when a donor had donated and was reaching across to get a snack and was dripping blood into one of the baskets. So yeah, they quit doing the loose snacks and did prepackaged. No alcohol until after eating, and I was astounded. I always learn from my students, and I'm always surprised. One of the gentlemen in one of my classes said, "Oh yeah, on Friday night we always go and we go donate blood." I said, "Why?" Because when you lose a pint or 450 cc's, you're going to replace that fluid by what you drink. And so when you drink alcohol, then it's more rapidly goes into the body and they become drunk sooner. So they then become a cheap drunk. I don't know. I found out that this is common knowledge, so I'm okay sharing that with you. Refrain from smoking for 30 minutes. If bleeding continues, apply pressure and raise the arm. If you feel faint or dizzy, sit with your head between your knees. The only time I had a reaction was the first time I ever donated in college, and I think I just hyped myself up. I wasn't all that nervous, but as I was leaving and going down the cement steps, I had to stop and sit down and put my head between my knees because I was feeling very dizzy. If any of the abnormal symptoms persist, contact the blood center. There may be cautions about returning to work. I know people who work construction on skyscrapers may be given the rest of the day off after they donate blood. Be sure and let them know when to remove the bandage. And then thank the donor. They are a precious, precious resource. We want to do everything in our power to make sure that this is not just a one-trick pony, that they will come back and be repeat blood donors. Upon leaving, the donor should be provided with phone numbers to call to report bleeding that reoccurs. If for some reason they feel the donated unit should not be used, maybe they were coerced into donating by friends and they know that they're hepatitis B positive, but they don't want anybody else to know. So they may call and say, "You know what, I donated today, but don't use my blood." And they don't have to give a reason. Just that statement alone will cause their blood to be pulled from inventory. If after leaving they have any type of reaction, or if in the days or even weeks following they experience signs or symptoms of an infection, so immediately call the blood center, tell them what you've been diagnosed with, and they will make the determination whether or not to pull that unit of blood from inventory. So these are some additional steps for processing donor blood. All reagents used for testing must meet or exceed appropriate FDA regulations. You cannot rely on previous testing. Last time they were HIV negative, so we don't need to do that test. Or last time they tested as an A pos, we don't need to do that test. Absolutely not. You cannot rely on previous testing. But the good news is when the previous testing matches the current testing, it makes you feel a lot better. The results of any testing must be recorded immediately, just like with any other lab test. When you're doing a differential, you don't mentally keep track of the sags and the limbs and this and then record them. No, you do it as you go along. There's a record system to track unit to final disposition from the day it is drawn until either it's transfused into a patient or it's thrown away. Unfortunately, blood has a finite shelf life, and we can expire a lot of product. The records must be retrievable, so you have to be able to say, okay, this donor unit was given to this patient, and we must be able to retrieve that record, because what if it's a case of a specific donor transmitting an infection to a patient? So that look-back process needs to be done. Records must be kept for 5 years or 6 months after the product expires, whichever is longer. Frozen blood is good for 10 years, so the 5-year limit would not apply. Some general considerations when processing the donor unit after collection: the numbers on the blood bag, the processing tube, and donor records should be rechecked prior to processing. So you did that at the donor side, and then you take this away and you put it in a central area where all the donor blood is kept. So prior to performing the additional processing, you do another check. One of the tests that's done is the ABO group and D type, including a weak D test that must be performed. A weak D test is a special test done. D is also known as RH. And I get annoyed when people say the RH type, because RH is a blood group system which has hundreds of antigens in it. D is one of the antigens in that blood group system. But because other healthcare professionals and old blood bankers were raised with Rh positive and Rh negative, unfortunately that has remained so far as labeling is concerned. But in the true nomenclature, instead of Rh type, we should be saying D type. Anyway, getting back to the weak D test, if you're testing for the D antigen and they're negative, you have to do a special test called the weak D, because some people may have a weakened expression of the D antigen. They're D positive, but they don't come down at immediate spin. Donors with a history of transfusion or pregnancy should be tested for unexpected antibodies. Unexpected antibodies are antibodies other than anti-A or anti-B, which are expected in certain blood groups. An unexpected antibody would be one that a person was exposed to an antigen and sensitized to this antigen, which is not their own, and they build antibodies. Well, these antibodies can then cause a reaction in a donor, so we want to make sure not to make plasma from them. So in discussing serological testing, we're not talking about infectious disease testing. We're talking about serological testing done on each donor, which will identify their ABO and D type. We will do an antibody screen, and this is to screen for unexpected antibodies. And if it's positive, you have to identify the antibody, and you cannot make plasma products from them. You can't do divide it into plasma. You can't make platelets from them. You can't do plasmapheresis from them. So the antibody screen is done on the donor plasma. Antibodies to other blood group antigens which are present in the donor may react with recipient red cells, resulting in a reaction. So for example, let's say I identified an anti-KEL antibody in my donor, and the plasma has the anti-KEL antibody. And then we transfuse this to a patient who has the KEL antigen. Theoretically, this may lead to destruction of those KEL positive red cells. Infectious disease testing methods. ELISA, enzyme-linked immunosorbent assay, is a method that can detect either antigens or antibodies. So bring back serology to the front of your brain. Chemiluminescence can detect antigens or antibodies. Bring that methodology back to the front of your brain. Detection of syphilis antibodies by the rapid plasma reagent test. Now they're finally coming up with an automated RPR machine, but in many places this is not standard practice in the field yet, so they may still be doing these manually. Nucleic acid test detects viral nucleic acids. These tests are much more sensitive, and it reduces the window period. If you remember from serology or immunology, the window period is the time from when you're infected to where there's detectable antibody. So you may be producing antibody, but if it's below the sensitivity of my test, we could get a false negative. NAT testing has eliminated this from the picture. So HIB, the window was dropped from 22 to 12 days using NAT testing, and HCV from 70 days to 10 to 14 days. So we have a much better assurance that these donors are negative for these diseases. Antigen, antibody, and NAT testing will allow positive results throughout the disease process. So all donations must be tested for the following infectious diseases and found to be negative for antibodies to human immunodeficiency virus, HIV-1 and 2, hepatitis C virus, human T lymphotropic virus, HTLV-1 and 2, hepatitis B core antigen, anti-HBC, and Trypanosoma cruzi, either on the current donation or at least one previous donation. And we covered Trypanosoma cruzi in immunology serology, so you may want to go revisit that material. It's not necessary to know the particulars, but if you're nosy like I am, I always want to say, now what was that again? The donor must also be found non-reactive for hepatitis B surface antigen and must be negative for the detection of bacteria. One thing that has prolonged release of blood into the general inventory is they do a test to detect bacteria. They have a plate that is collected and it's incubated, and I can't recall if it's 1 or 2 days, but the donor unit must be negative for the detection of bacteria. This is more of a problem with platelets because they are stored at room temperature. So continuing on with the types of disease testing, the donor must be non-reactive when tested using licensed nucleic acid test, NAT test. Hepatitis B virus that detects the deoxyribonucleic acid, HCV ribonucleic acid, HIV-1 RNA, West Nile virus RNA, and Zika virus RNA. Zika's the new kid on the block. If you remember a couple years ago, it made the news because it causes that horrible brain disorder where anencephaly or even portions of the brain are missing. The donor must be non-reactive when testing using a licensed serologic test for syphilis. So once again, I want you to know all of the infectious diseases. I want you to know the types of testing that's done, whether it's a NAT test or a serological test, and then know that all disease markers must be negative or within normal limits. Donor blood which falls outside these parameters must be quarantined, and if the repeat testing is performed and if it's still abnormal, the donor unit is disposed of. And the donors are notified of the results of testing that are abnormal. I've listed some optional tests that may be done on donor blood that you must be aware of. CMV testing, cytomegalovirus. This can cause a devastating infection to premature infants and to those individuals who are severely immunocompromised. Removing the leukocytes has greatly reduced the risk but not eliminated it. Some physicians will still request CMV neg for select patients. For example, we continue to give our transplant patients, whether it's heart, kidney, whatever, CMV neg because they're immunocompromised for the rest of their life. They will be on immunosuppressive drugs. And for our babies in the neonatal intensive care unit, because again, this can cause a really devastating, fatal infection in them. Special antigen typing. What do I mean by special antigen typing? Well, patients may develop antibodies against other red cell antigens, and we're not talking about A antigens or B antigens. Those are expected types. We're talking about, for example, anti-Cal, anti-KID, anti-Duffy. And let's say I have a patient that has all 3 of those antibodies. I don't have the resources to screen my units to find antigen negative. So I will call the blood center and ask them to screen their donors and find me whatever I need, 2 units, 4 units. And because of computerization, they can easily identify donors who are negative because once they phenotype a patient, that stays part of their permanent record. But if in their records they can't find anybody, especially current donations, they may need to call somebody in. Sickle cell testing, this must be done for a procedure called exchange transfusion, which when we get into hemolytic disease of the fetus and newborn, we will talk about that, because this is something that is done on newborns who are severely affected by hemolysis. So individuals who have sickle cell disease will absolutely not be donating blood. They're good to maintain a hemoglobin of 6 to 7, which in their world is excellent. But if you are a carrier, if you are a heterozygote, then you won't know that you are a carrier unless you're tested. And unfortunately, people with sickle cell trait, if they get overly stressed or if they go to regions of high altitude with limited oxygen supply, they can go into sickle cell crisis. But the majority of sickle cell trait people, they may suspect that they are a carrier, but they don't know for sure until they're tested. So sickle trait may sickle in neonates due to their unique physiology. So because of that, every donor unit that will be used for an exchange is tested and must be negative for sickle cell. Labeling donor units. Oh my goodness. The amount of information that must be on every unit of blood has increased substantially from when I entered the field. So we always had to have the component name, a unique donor number so we can track that unit back to the individual. Have to do the ABO group, the D type. The D type is not required for plasma. The D type is only for red cells or products that are very contaminated with red cells. Interpretation of the test must be on there, and I'll show you an example on the next slide. The type and volume of anticoagulant we're going to talk about. There's several different anticoagulants and the amount of anticoagulant in the bag, because this can affect, it may dilute the blood, so we need to know what that concentration or the volume is. The storage temperature. Some components are stored at room temperature, some at 4 degrees, some in the freezer. So it has to be indicated on the label what the storage temperature is. The expiration date is crucial. Blood cannot be transfused beyond its expiration date. The name and address of the collecting facility is very important. There have been times that I've had to get blood from another state because I had a patient who needed rare blood. So knowing the name and address of the collecting facility is crucial, because it may not be local to you. Reference to the circular of information. I really want you to take a little bit of time to review this document. I've also put a copy in the reference portion of the course. This is primarily for doctors, and it tells them about all of the different blood products, what the indications for transfusing, and it's just a wealth of information in a little pocket-sized booklet. The donor classification, whether it's volunteer, autologous, directed, results of testing, and again, when you see the next page, you'll be amazed how they can get all this on the front label, and pooled component information. For example, cryoprecipitate is a subproduct from a whole blood unit, and it takes 6 to 12 units of cryo to be a therapeutic dose. And so we put it, instead of giving them all these 12 little bags, we go ahead and put all those different bags into one bag. And that makes it, in our opinion, much safer, because maybe the nurse is busy and one of them fell behind the table or under the bed. So if it's a pooled component, it has to have the information about all of the donor units that are in this pool. So when you have time, I want you to spend some time with this slide, because it's just amazing how much information is transcribed onto the label of every unit of blood. Every transfusion service, every blood bank in the hospital will have a required inventory of blood products. So when we start getting low, or when our products start reaching out date, we'll get fresh product from the blood center. The only repeat testing required by the transfusion service is the ABO type on all the red cell products and the D typing on D negative red cell products. The reason we don't repeat the D typing on D positive, because it doesn't matter. If a mistake was made and this D pos unit is actually a D negative, it will not have any negative consequences to the patient. No other testing is required. So all the disease testing, we take the word of the blood center that all the testing has been done and it's all correct. If we had to repeat all the disease testing on each donor unit, that would make the price of blood go out the roof. So again, we only have to do the ABO and D typing on negative products. Plasma products do not require any testing by the transfusion service. I used to get nervous about this because especially plasma, there's a large volume. What if this group A plasma was really a group O? And there's anti-A antibodies in that. But it has been found that even if that type of error was made, the dilution effect of putting the plasma in will dilute those antibodies out so much that they will not cause hemolysis. Donor samples must be stored at 1 to 6 degrees for at least 7 days after transfusion. I'll say that one more time. Donor samples must be stored at 1 to 6 degrees for at least 7 days after transfusion. And for Adsol, which is an additive solution, Adsol units transfused today, you must save the sprig for 7 days post-transfusion. Many facilities, to get around this, will pull a sprig from each donor during processing and save all the sprigs for 49 days, regardless of expiration of the unit. So that way we have ourselves covered. So I wanted to show you a picture of what I meant by sprig. So you can see this is the actual tubing that was attached to the needle that was in the donor arm. Once the needle is removed, they have a special machine that will actually put a seal between each, periodically through that tubing. And so these are called sprigs. Some people call them pigtails. I don't know what other people call them, but however many sprigs is on this donor unit is how many times it can be cross-matched on a patient. Because many, many times we will cross-match blood for patients, especially surgery patients or obstetrical patients, and they don't need it. They don't use it. So rather, if we only had one sprig, we could only cross-match it one time. So by having multiple sprigs on the donor unit, then we can cross-match that donor many, many times. I think they make about 50, which rarely do you pull 50 sprigs off a donor unit. So in summary, blood collection starts with screening of the donor to ensure they're healthy enough to donate, to protect their health, ensure they do not have transmissible diseases. So that's to protect the health of the recipient. Many organizations are involved in setting the standards and monitoring all aspects of blood collection and administration. The collection of blood must be done in such a manner as to ensure sterility of the component. Testing of donor blood includes serological testing for ABO-D typing, antibody screening, and testing for infectious disease markers. The blood supply is not safe. It's never been safe. Only careful screening and testing can prevent, as much as possible, disease transmission. And I remember I entered the field early on when HIV was just becoming a problem. And we were lied to, and which to this day makes me angry They said, oh, it cannot be transmitted through a blood transfusion. I didn't wear gloves. There were many times I was so busy that I had blood on my hands, but I'm not going to let a patient bleed to death while I go wash my hands. So then they discovered that it was transmissible through blood. Oh, the blood supply is not safe. The blood supply is not safe. Gee whiz, kid, it's never been safe. It always had the potential for hepatitis. It always had the potential for CMV. It always had the potential for a myriad of different diseases, bloodborne diseases. So again, I want you to keep this in mind, that the blood supply is not safe. It will never be safe until we come up with a process that can 100% remove or inactivate infectious agents in the blood.